We're here.
We are here, wherever here is.
Thanks for doing this. This is going to be awesome.
I'm very excited. It's very self-serving on my part, just because I've gotten a lot of texts and emails and stuff, and so I had this conversation individually, and so now if we release it, I can just say go to the podcast. Go to the podcast.
Yeah. I have other ideas for this too, by the way, where I could just come to your podcast and ask for help.
I like this. Yeah, and then we'll do the board stuff in the spring. It'll be fun.
Yeah. So I think we should to share what we're going to do. So basically, the concept here is that you and I have been talking about radiating for osteoarthritis for a while. I think your review article that you published that we did a podcast on really inspired a lot of people to kind of start thinking about it. And so that I was one of those people. And so I got to this new job and I decided I was going to share this with my partners, and they were actually very enthusiastic about it. So now we're kind of ready to build a service line. So I thought we would kind of talk about how you might do that, and then how we actually deliver radiation for osteoarthritis, because I thought it would be very helpful for myself.
Yes.
And you thought it'd be helpful for everyone else. So that's why we're here.
Everybody wins. And also, the really big props to Austin for his extra Genesis webinar, which as far as I can tell really was incredibly well received and received a lot of attention. So Austin is just continually making me feel like I was a very lazy resident.
Yeah, I mean, I heard that and I need to watch it. So I think
so Austin, I'm just so lazy.
Well, in the review article, so it was so nice because I literally wrote like a 5-sentence email, and I attached the article and I just said, read this, and then it got everyone interested. So I did like very little work.
The review article has become my new business card now. So I literally, I just print it out and then I highlight my name, and then I say, here you go, and write my email at the top. And so a red journal pre-proof, it's still in proof, I think, the one I pull off the website.
Is it really?
Yeah, I'm pretty sure, because it hasn't been quote unquote officially published yet. And so I just, print it out.
Yeah. Well, what's funny is it feels so slow because the world's moved so quickly, it seems like.
Oh yeah.
But they're actually pretty quick, I think, compared to other oncology journals.
Oh, without question. Yeah, that's why it's actually funny, because that's my default expectation now. And so, and then I kind of remember, this really hasn't been that long, even though I feel like I live in a time dilation, environment, and 1 year ago it feels like 1,000.
It does. So the only other thing that's cool is, the way I'm approaching this, just to, I guess, give a little more context, is that I found out that there's the employed. So I'm part of a big network. I'm at a little hospital in a big network, but attached to a little hospital is a few big practices and services, and one of them is actually ortho that does hips and knees.
Yeah.
So I've had a huge number of heterotopic ossification referrals in the first couple of weeks, and I'm also very excited to kind of talk to them about this concept as well, because I think we'll all kind of work well together on it.
That'd be perfect. Yeah. And I would love, I can feel the eye rolls right now, but I would love to do heterotopic ossification episodes in the future, but we'll save that for another day.
Yeah, it's interesting, actually.
I taught it as when I did the palliative and benign section during the resident education stuff in residency, and that was my topic. So
I did a fair bit at WashU as well, because it kind of it fits naturally with the other service that's radiating, like bones and joints.
Yeah, you really, the stars aligned. I feel like that's all right. We'll put a pin in that turbo nerd conversation for a future episode.
Yeah, so to dive into it, I guess the first thing that I wanted to ask you about was about how people generate referrals, because I've heard a little bit of this in the way that, so we have our first patient coming up, and that's kind of what inspired doing this. And the way that I kind of did the first one, which I think is similar to some of the other people, is that I was talking with one of the patients that was referred to me for an oncology indication. It was for a breast cancer. It's an elderly woman. And we ultimately decided to recommend against radiation for this person, but they have very bad joint pain that's longstanding. And they literally talked to me about how they're afraid of needles and didn't want to do anything interventional for the knees, because everything that was offered was kind of too, quote, invasive for her taste. So we started talking about it, and she's very interested, and we'll hopefully be doing the CT sim soon. So I don't know if you've kind of started your practice the same way, or do you have other?
Yeah, that's basically the story as it goes on my end and on many people's end. So on my end, um, I haven't actively engaged in sort of classic practice building in terms of kind of networking with relationships and trying to generate additional referrals, simply because the site that I work now, which, while there's no official announcement yet, I will not be here for super long, so we'll be different in the future. But so because I'm
Teaser.
so busy, yeah, that we'll just tease. We'll do all these teaser things. So yeah, I watch the space. So there'll be much bigger things coming on in the next few months. But so because I'm flat out with just regular referrals, I haven't tried to kind of open the floodgates on this, as it were, because it will be floodgates. Because essentially, the story you told is basically how it always goes for me. And so I will look, and it is also usually kind of a breast or prostate, but it's usually the breast patients. And so it'll be either during OTVs or during follow-ups, and I'll see on our just standard intake form that has existed since, the beginning of time, that arthritis or osteoarthritis is just a checkbox on the intake form. But more often than not, it's actually just kind of organically comes up in conversation. My favorite being a couple months ago, one of my breast patients during OTVs was just cruising through, because within the current breast regimens and everything are pretty straightforward. So she was kind of just lamenting that she really had nothing to complain about, which we laughed and joked about. And then she's like, well, I do have, what did she say? She's like, well, my knee's really bothering me. And they started talking about surgery. Can you do something about that? Totally joking. And I was like, well, yes, I can. And that was, and so that's kind of how I've been doing it. And I think pretty much that's how everyone I know, obviously we have one mutual friend who's actively kind of advertising and engaging that, which will be a different episode. But yeah, so I think it's basically just kind of word of mouth with existing patients. And then orthopedics is kind of where everyone defaults to. And that makes logical sense, or for you with a built-in sort of referral stream. That's one thing. But I also kind of, when I engage in this more kind of with intent, I will be speaking more with PCPs in family practice and sports medicine.
That's actually what I'm doing now. So
Nice.
this is, again, just, I think one that it would be fun to talk. I think it's so fascinating how I just imagine that radiation oncologists have very different experiences starting a new job, just depending on what's robust where you are working,
Yep.
it has such a huge influence on what you do day to day. So they just basically they're developing these these big primary care practices that are employed. So I've actually been spending a lot of time with them, and there's other reasons for it as well, but this is absolutely one of the things that we've been talking about.
I love
'Cause
that so much.
yeah, because I think that I think that what's really nice about primary care is, they obviously manage all, lots of important things for the patients that we share, but they're also they're really involved in kind of navigating patients into the entry point of whatever treatment pathway that for whatever
Yep.
they need, right?
Yep.
So they have a really detailed conversation about the arthritis, and they will know if the patient doesn't like needles, for example. And just knowing that we do this, I think, is another tool in their tool belt to be able to help their patient feel better.
And I did,
So
yeah, I forgot about that. But so when I've talked to most people about this, and the people I know doing it in America, at least, that's kind of the way we're all approaching, is it's still in a referral based sort of pattern. And so I have not been actively engaged in being the primary diagnoser of it. Now, when I talk to people in Europe, so I had a meeting a couple of weeks ago with one of the Europeans who does this, and they were much more interested in developing kind of more robust resources and in kind of beefing up their own knowledge on being the primary kind of the one who diagnoses and works it up, which I think will be something that we could explore in the future. That's traditionally in America not something radiation oncology does. Or, well, again, we're rebanding radiation medicine for this reason. So in radiation medicine, that's not our role in this moment. It doesn't mean we can't do it, and so I've been cheating.
Yeah.
I think most of us are cheating in that patients come to us already with a diagnosis of osteoarthritis already being worked up. But I think having us be kind of the touchstone and the point of care for that is certainly something that's well within our abilities.
For sure. Yeah, I agree.
But that,
So we should we vowed to keep this a little short. We should move on to some more practical stuff. So
yes.
so I did we did exactly, I did exactly what you said. I actually let her think about it for a while because I wanted her to resolve all the oncology stuff and kind of get that finalized. And then I called and so I'm actually getting ready to do my sim. So I actually was asking you some questions today about how you would do this. So I'm guessing you use a CT sim, or I don't know if you want to.
Yeah, no.
Should we
Well,
refer
so I
to
guess, and to back up a little bit
Yeah.
further, because the one sticking point that I see a lot from people is, before we even get to that point, is billing and like what ICD-10 codes and CPT codes and so on and so forth. So, you know, I and everyone I know who does this in America, we just will use the ICD-10 codes for the relevant osteoarthritis. So, I will specify, you know, osteoarthritis of the left knee, just like any other. So there's no trick to that. It's literally just that. And then in terms of the CPT codes and billing, it just same stuff we've already been using. Although we'll get into kind of 3D versus complex isodose and stuff. But so really just to really emphasize, there's no tricks, no nothing. It's literally what you already do. Just use the arthritis ICD-10 codes. That's it. And so
That's
yeah.
Yeah. No, that's actually, it's funny because that question exactly came up from my billing person today when we were talking about this.
Yep.
And so I just very confidently was like, yeah, put it's osteoarthritis. That's what we're going to put it in as. And yeah, I didn't really know. So I'm happy
I
with
like,
this.
yeah, you gotta fake it till you make it. I can't, I have the other ones. Like I know, you know, 79.89 is unspecified secondary malignancy of overlapping sites, but I don't have the ICD-10 codes memorized for arthritis yet. But so, yeah.
Yeah, they're in there though. They're in Epic, and I was able to like enter it for the patient.
I think they're like
So it's-
14.42 or something. Well, whatever. We'll Google it later. But yeah,
Yeah.
I think just to really drive that home, because I think that is the most common concern, the most common question, is that there's nothing cute about this. It's just really straightforward. So ICD-10s for osteoarthritis, if that's what you're doing, because then there's also plantar fasciitis and whatnot. But yeah, for me, you know, and I think especially for the Europeans as well, I definitely start with a CT simulation. So I guess for your patient is a knee, correct?
Yeah.
Okay.
Yeah, it's gonna be neat.
And that's what I see a lot of. I think that's incredibly common. So using the knee as an example. So, you know, after consult for CT sim, basically I set it up very similar to any other knee thing. Now, and you and I have actually talked about this a lot before for like immobilization. So, you know, and I have, you know, I know this is going to be audio only. So Matt and I are looking at some PowerPoints or from some papers from Korea and from Spain. So you know, there are the Spanish and kind of the Europeans and stuff, they will use classic sort of custom immobilization. So VacLox, Aquaplast for various parts of the body. We were just talking about Orfit before we started, things like that. So you can get as fancy as you want with it or as basic as you want with it. And so I've definitely done knees and standard sort of, I make sure you do feet first. So up, not, you know, it's supine feet first, just because of the standard Linac is going to struggle with that if you do the head first position.
Yeah.
And I generally, so I don't do a VacLock. What I like to do, and I love that I'm talking to a guy who knows about 800 million times more about sarcoma than I do. So for my extremity choice for this, I will take foam blocks and I will kind of insert the foam blocks or have the patient kind of rest their legs and use foam blocks between the ankles and kind of do, it's not like custom immobilization in that it's not a VacLock, but I will make sure that it's reproducible by using sort of those assistive devices. And I actually don't know, I'm very curious if you do that or what your lower extremity setup would be.
So I have to admit that I don't know for my new practice because I haven't done a lower extremity yet.
That's right. See, and that, the adventure begins.
Yeah. So, but you know, I think it's like it's funny because if I was doing this, depending on the patient, I potentially, well, you know what? Actually, we have this. So this actually ties into something we talked about earlier today, as well as the imaging, right? So I guess if we're not imaging daily, I'd probably do something. And so I'd either use, like you said, like a foam. They make these foam, like knee molds.
Yeah.
Kind of that. Yeah. So I'd use something like that, or I'm actually not sure what will happen with this new system, so I'll tell you.
I'm very curious, and this is going to be true for everyone. Is that, you know, I always kind of thought that there is a much more standard way to do immobilization and stuff, and there most certainly is not. And so I guess as always, we can always cop out and say talk to physics. So yeah,
Yeah.
I don't do IGRT or daily. I don't do daily IGRT. So having a higher degree of immobilization up front gives you more comfort. That being said, of course we're doing 50 centigrade doses, so it's not like you're doing anything. It's not like you're doing trigeminal neuralgia SRS. So
yeah. Well, it's funny because it's actually hard to talk about this in sequence because you have to kind of talk about all the details
right.
to make intelligent choices. So I guess it seems like the way that this is going to be done is basically APPA with a relatively big field with margins, and so you could potentially do something more comfortable and less immobilizing even without daily imaging. But I agree with you that if you're not doing daily imaging, you need some kind of you can't just put them on a pad,
right.
which is what I'd maybe do for a palliative treatment if I'm daily imaging for it.
Exactly. Yeah. And that's, that's a really good point. And I had forgotten that there are other. Oh, I'm very excited about this, but yeah. So I generally there's nothing wrong with doing a vac lock or something like that. It's more just that's cumbersome on the therapist and kind of the setup. Whereas doing kind of a midway between just using a pad and doing a full vac lock sort of setup, there's kind of a middle ground, which is going to be practice specific. So I personally right now am using combinations of the knee rolls and foam blocks and tape and stuff. So the other thing about this, which is talking about trying to talk in sequence and failing. So, I will by reflex design a repeat course just because, if you look at a lot of the data, a lot of the significant sort of where you see those 80-90% sort of relief come from 2 rounds of it. So I'm trying to plan ahead. So at the time of that initial CT simulation, I will, we'll take pictures just like normal or whatnot, but then I'll also do a circumferential measurement, which is like a standard sort of tape measure, because if you so choose, depending on what goes on, for that second course, if it's going to be indicated, you don't have to re-simulate, which, I think some clinics and some people would get very kind of nervous about. And so, but in the ultimate form of choosing wisely, and if you're at a place that's going to be okay with it, you could theoretically just deliver that second course, 2 months later without re-simulating. I would just measure the circumference and check the pictures and stuff, but just to put that on people's radars. But I don't know how many people would be comfortable with that.
I think it's very reasonable.
Yeah.
It's like it's such low dose. I actually am excited to look into the physics a little bit because I wonder how the QA does, and it's just such a low dose.
I wish if I was better at this, I would have had my portal dosimetry pulled up to shoot. Okay, well that's a pro. Yeah, we'll do that in the future. That's a good point. It is very, and it's really funny because, and this is something I rant about all the time, where people treat the treatment planning system images as like gospel. So people will look at like a clips and just obsess over these ditzels, and it's not real. And so it's even funnier when you do this and the colors and the things that the way you evaluate a plan, it all looks the same until you actually look at the doses and you're like, man, look at that hot spot. And then you realize you're talking about a total, a 50 centigrade. So 110% hot spot on a 50 centigrade. It's not that hot.
Yeah. So, okay. So basically we set them up. Excuse me. You do a CT sim for these patients, and then maybe potentially one for the second round. You don't actually prescribe it up front, though, right? Like you would just prescribe the 3 gray as a course, and then if they do come back, you would do a second course. But
correct, yeah. So the way,
you may not.
So basically, how I do it is, set up the CT sim. However, depending on the anatomical site, if it lends itself, so the no resim really works better for like knees or stuff, or extremities, or if you do like hands with aquaplast material and you keep that immobilization, those sorts of things. But there might be anatomical sites where it's just not feasible. But so in the initial one, after the CT simulation, just like normal, everything else then just becomes normal, where they sit down with the patients and they talk about a treatment schedule. And I do not by default prescribe that second course. What I'll do is I schedule the first follow-up at 8 weeks, and then with a plan to roll right either into like re-simulation or replanning at that time. So I definitely don't prescribe up front.
Yeah. And so, okay. So, and then before we move on to targets and kind of how the beams are delivered, my other question for you is, do you do anything central? Because, you hear a lot about this for hands and knees and shoulders. Now, I think doing central would be very reasonable, but you could imagine the argument against it is that you're now giving some low dose radiation to visceral organs.
Absolutely.
So things like sacrum or SI joints, or like, you know, hip, medial hip. I don't know. Hips kind of a bad example because I do hips all the time for HO.
Yeah, I was gonna say, don't we? Yeah, it's no, and that's another incredibly common question. So I guess what we skipped was inclusion or exclusion sort of criteria. So me personally, I like to have patients older than 50, whereas I know there's a lot of Europeans who are doing it older than 40, so younger than me. And then I have been, you know, in these initial sort of rounds here, sticking with extremities. So yeah, hands, shoulders, elbows, that whole deal. That being said, you know, I personally know people who have done central, you know, targets like lumbar, sacral, spine, those sorts of things. I know the Europeans do it all the time, and in that Spanish atlas we'll talk about, there's a lot of kind of details on that. So I have just personally been being ultra conservative, which is really funny to say as one of the people really pushing this in this country, that I'm kind of paranoid about this. So in my heart of hearts, I do not believe that there's a risk of secondary malignancy. I don't believe that there's like really any sort of severe side effects. I'm literally just doing it out of sheer paranoia. I think it works. I know people who have done it and rave about it. And but yeah, so I will eventually be doing it, but I'm just trying to keep a steady course.
I think that makes you a good radiation oncologist. It's, you know, one thing we also didn't talk about is you probably could do like a low dose sim, like CT sim.
Oh yeah, I've gotten really into. There's some cool tricks you can do if your physicist will tolerate you. But
yeah, I mean, just because, you know, like I think that I agree with you. You know, the risk of a secondary malignancy, which is a horrible toxicity, probably approaches the same numbers as other weird horrible toxicities from other types of procedures that people do for joint replacement.
Yeah.
So I think it's you know, we're really on the same playing field here. It's a totally valid treatment to do, even for central. But that said, I think there's no reason not to minimize, you know, radiating unnecessary tissue.
Yeah,
So,
I think, and
you know,
we'll link all these things up, because I know I think it was published recently. The Germans, it's always the Germans. The Germans had this great study looking at specifically shoulder treatments and the incidence of breast cancer. And as I recall, it wasn't statistically significant, but I think the rate of breast cancer in the people who received low dose radiation was slightly less than those who didn't, which was very interesting. But so there's no literature.
Hormesis.
What's up?
Hormesis.
It's always hormesis. Yeah. Don't blow up my business spots, Matt. So the rate online.
So for targets, so this is actually what I'm really interested in, because I wanted to ask this to you all day, but I already asked enough questions. So once you have, let's just, like, I guess for the knee, is there a figure in this paper about,
there is. I don't have it here, but there is definitely here. Let me scroll over. Super exciting for people listening at home to hear me click.
Because you know, the question, you know, what's funny is there's actually like a lot of in the sarcoma world, it's not entirely clear what the proper way to contour like the joint space is.
Oh yeah.
So is that red square the target? Because that's like,
yeah. So
that's what I imagined it would be.
It's pretty, because the real thing is don't get cute in that don't do postage stamp fields. And so this and the intro to the Spanish Atlas talks about it, because your target is really kind of the joint apparatus, so including like the joint capsule, the attachments, the synovial fluid, blah blah blah. So what I personally do is I will kind of, this is kind of weird to describe, like how I just sit there and actually do it. So I find the middle of the knee joint, and I look at the, you know, what the actual kind of Z plane is on Eclipse, so in the little lower left-hand corner. And so say it's like -1. I then go up to, you know, or go down to -3. So I go 2 centimeters below and 2 centimeters above. I draw my lines there, and then I just basically make like I essentially, well, you can either just draw a PTV, which I know is sacrilege in this day and age, but I will basically just often draw a pretty generous PTV, making sure that it's kind of 2 centimeters above and below, and making sure that that's rational. So if you have like a really short person, that might be like insanely huge, or if you have a really big person, that might not be big enough. So I generally kind of aim for the mid plane, 2 centimeters above and below, and make sure I'm like capturing all of the stuff.
Yeah. And actually, so I had, just, even though I'm a recovering sarcoma expert, I had to look this up. But so what I thought it would be is you'd be covering the condyles on both sides, kind of getting the entire joint in the center, and covering, you know, a centimeter or two of the proximal and distal femur and, and tibia.
I think, yeah,
So
and I think that's the default. I favor, because it's really hard to see kind of the capsule and stuff on just a regular CT. So I favor erring on the side of caution, being a little bit more generous, just again because the doses are so low that you're not going to have any increased side effects. But I personally, reading like the kind of the mechanistic papers, like the in vitro and the in vivo stuff, I think a lot of this is just kind of signaling mediated, and so I think making sure you hit all of the membranes and the capsules is important.
Yeah. Probably the insertion points of the tendons too.
Yeah.
Like maybe.
Yeah. So I really deeply believe in that. And so that's why I'm a little bit more generous, is I want to make sure I cover all of the tendons, the capsules, the insertions, and all that.
Okay. Yeah. And I think, so I guess you'll post this picture, but to me, it also looks a little, I'd probably have a couple cm around the bone or laterally, just to have some space there. And so I think probably I'd end up blocking the corners because, we don't want to radiate, fat or whatever.
Oh, that's
muscle.
so. The knee is a perfect example for this. So we're all taught, and everyone's scared about the don't do circumferential irradiation. So this is not sarcoma. You're not taking it.
Just a high dose, though.
Yeah, exactly. So so if you're going to like 60, 66, yes, absolutely, that is accurate. But when you're doing 50 centigrade times 6 for a total of 3 gray, you can do circumferential radiation. You're not going to cause lymphedema. But that's a common thing I've heard too.
Yeah. Oh yeah, no, it's. I mean, you need a lot more dose.
You got to spare the strip of skin, Matt, or otherwise you're going to radon jail. Right. Don't go to radon jail.
I mean, it's like if people are worried about 3 gray, they should look at a sarcoma plan, and they'll see that the whole leg's good.
I've used that, yeah. So especially because this time of the year, it's a nervous new attending time. So whenever people freak out about hot spots or stuff in muscles, I'm like, think about the sarcoma people. They're you're nowhere near that. So. Thank you, sarcoma attendings, for giving me talking points to take people off the ledge. So yeah, that I err on the side of caution, and I just really reading the mechanistic papers. I think that does play a big role in it, and hopefully as we all kind of engage in more research in this as the years drag on, that will bear fruit. But that's just kind of how I practice that, because the default, and this is what I've seen people do, like the logic, if this is not something you've done before, is that, oh well, the joint is what hurts, therefore the joint is the target, and it's really easy to think you're being generous by covering the actual like joint space itself, but you're really missing a lot of membrane and tendons and stuff.
And I remember from med school, aren't there like bubbles in the bone?
Bubbles in the bone. Yeah, actually, this paper, I love this bubbles in the bone. Yeah, that's a thing. We're doctors. Let me see. Yeah, so
subchondral.
Yeah, something. But this Spanish atlas actually has great netters pictures and stuff. And yeah, so
this is great. I didn't know this existed. So
I'm obsessed with this. Yeah. So the paper for listeners at home, it's called. It's from 2021 actually, so is accepted on June 8th, 2021. The first author is Alvarez, and the senior author is Rubio, and it's radiotherapy CT-based contouring atlas for non-malignant skeletal and soft tissue disorders, a practical proposal from Spanish experience, and it's done in the British Journal of Radiology. So it all timed together. This paper is incredible. So, and then, Austin, Dove, and I, we're working on kind of a practical guide, and we'll get stuff up on the web. So, like almost, the e-contour of benign diseases. So we're working on that. And if people want to help us with that, because my bandwidth is pretty much peaked at this point. So, but we'll try to get these things up in an accessible format. But yeah, so I highly recommend.
I saw that in the picture. they have like a 5-point mask on a person.
Yeah.
Probably for the shoulder. I'm guessing
you got it. The head and shoulders mask is really important for 3 gray. And well, it's this. So in figure 1 of this paper, I've never seen what you can do. There's so many things with aquaplast that I'm not doing, and I love this. There's a picture of somebody with 5-point mask and bilateral hands inside them. Oh, I'm doing this. Oh, I have a hand sim coming up. Actually, I have okay. I have a bilateral hand sim I'm doing. I'll do this.
I love seeing how people do this stuff. It's pretty
This is
interesting.
great.
'Cause I just like how there's so many different ways to kind of do it.
Yeah,
Well.
and that's something. Again, that's the whole point of doing out of the basement and having these conversations. Is if I've tried, I remember as a resident banging my head against the wall, where I'm like, I wonder if there's an atlas for how to set up, because it was. I remember as a PGY2, somebody asked me, it was like, oh, Jason, what's arms akimbo mean? Like classic PGY2 pimp question, and so that sent me on this rabbit hole where I'm like, oh, clearly, just like all other things, there's got to be a great book on setup techniques, and there is not. So we'll work on adding that. We'll do it ourselves. Yeah. So
We should write one in the style of like the old books.
oh yeah. If I could draw, well, yeah, I have no drawing ability, so I'm gonna try to do like Netter, but it's gonna look like a child drew it. It's gonna be great. They'll name it med school after me.
So we okay, so we have the targets there, so kind of APPA, and then you basically are building like an isodose plan,
right? So I think
in a complex
yeah, that's the important thing. So there's a couple different ways to do it. So if you go in the EviCore guidelines, so EviCore is the benefits manager for a lot of especially Medicare Advantage programs, but so the EviCore guidelines specifically say that they will approve complex isodose. Now, technically a misnomer, because if you're really doing complex isodose, you need a conventional simulator, and none of us do. And the way EviCore chooses to define three-dimensional radiotherapy is the generation and evaluation of a DVH, which probably made sense 20 years ago, but literally every single TPS on the market is doing that without you even asking it. So it gets a little tricky. So, to be ultra safe, I think billing as complex isodose is kind of bulletproof. So not doing daily IGRT, and certainly not billing IMRT, but and not billing as 3D and billing as complex isodose is the way to go. Now, if you're making a PTV and you're prescribing, so I am like anyone else raised in the VMAT era. I always prescribe to the 100% isodose line, which is the edge of my PTV. I'm prescribing to a volume. You could prescribe to midplane. A lot of Europeans. So in the Extral last year did a benign radiotherapy like symposium thing, and that was a common question. And so there's a lot of Europeans who are just kind of prescribing to midplane, but the Europeans are also using a lot of orthovoltage, which I will try to bring to America by buying my own, but that's going to take me a little bit of time. But
I wonder if is it simple, because I did really want to try to keep this short, so I could not. We always go. So the background on that, just so people know, is that I was gonna try to make my wife happy by not going over, because we go over.
Yeah, we're gonna be great. We're gonna make our wives happy, definitely.
But like when people do this, when they're prescribing to midplane, they're not using the TPS. Like I feel like it's still worthwhile to kind of use the TPS.
I strongly agree.
And I was also going to comment that I think it would be very reasonable to do a PTV and do 3D for like a sacroiliac, like they have highlighted on this paper.
I completely agree.
Yeah, but for a knee, it's kind of hard to. There's like nothing to block, right? So it's kind of hard, or nothing to like
Yeah. So it's funny because the way the TPS is the treatment planning softwares work, you'll be doing it anyway. So yeah, I think, but just especially if you're treating someone with Medicare Advantage plan managed by EviCore, as long as you do 6 fractions complex isodose, it'll go through without issue. And so, but I agree. Prescribing PTV, 3D, blah blah blah, I think is incredibly reasonable, but. Future episodes where we talk about CPT and RVUs and stuff. But so yeah, that's really, and then I do 3 gray, so 300 centigray delivered in 6 fractions, so 50 centigray each fraction. I've also done 60 centigray in 5 fractions depending on timeline. So the take home is I really believe that, and the data I believe because of the data, that 3 gray total is important and that 50 to 60 centigray is important. I think going above that, because you're not trying to necessarily kill cells, you're trying to alter cellular signaling and leukocyte adhesions.
And you do every other day, right?
Yes. And so this is and it's funny because that's how I personally do it. But then when I was looking at this Korean paper from 2017, the Koreans do it in 1 week, so 5 fractions a week. So I've definitely done that. So one time I had a person who was visiting and only had a short period of time and could really only be in town for like 2 weeks. So, and for her, I did 60 centigray in 5 fractions delivered in 5 consecutive days. There's that hasn't really been locked down, but I think Degro, which is the German Astro, recommends 2 to 3 times a week, which basically 50 centigray every other day.
Okay. Yeah, and we talked a little bit about this, I think, a while back, right? I mean, obviously, you should you should float this question to like Rad Bio Twitter. I'm sure they'd go crazy with it. But like, there's probably, I mean, it's hard to know if there's a difference, right? The dose is so low that the timing probably might matter
Well, I
more.
wish, and that's
And
the one paper, like the naysayers like to cite that paper that was negative, that came out a couple years ago. But in that paper, they used 1 gray. So I agree. I think that that study would be great, where it's 50 centigrade, and is it, consecutive days or every other day. What the trials
yeah,
always end up being, or the studies always end up being, is always comparing like either 50 centigrade versus 100. So, 0.5 versus 1 gray, or something like that. There's never been, to my knowledge, and somebody can correct me if I'm wrong, there's never been that timing. So maybe Matt and I will just do it ourselves. So, but yeah,
yeah. I mean, I don't know. I have to read some of these Rad Bio papers and kind of see what
yeah, they
they
focus more. They're
what they
great. I mean, I know I sent you. There's a 2012 review, also from the Germans, that kind of summarizes all the in vitro and in vivo mechanistic data, which is pretty amazing. Like, as someone who has a radiation biology PhD, because I was getting like Western blot flashbacks reading this paper. But yeah, so it is more about interleukin signaling and.
so so it'll be hard to read for me,
Yeah,
but
yeah.
we'll
We'll
try to
hold
get
you.
my
I know
buddy.
you had to study DNA PK for Rad Bio boards, but yeah. So for me,
I
it was
did.
nostalgic. For you, it's probably brings tears to your eyes. So
I was always more of a physics person.
nerd.
So this, so you do one OTV, and then you kind of mentioned it already. You kind of do your 8 week follow up with plan to potentially retreat. And is it just kind of a clinical judgment? Like if they're not happy with their pain relief, is that kind
Yeah,
of
so in some of the more recent stuff from the Germans have also kind of talked about this, and if somebody comes, so actually it's funny, the week the Red Journal paper got released, I had one of these patients come in, and she had 100% pain relief. So she came in, and I was geared up, like she was on. I told all my therapists and stuff that we were going to resimmer, blah blah blah, and she came in and she said she had 100% pain relief. She didn't think that the second course is necessary, and so I said, fine, you call me if you need me, and otherwise have a nice life. And so whenever that paper came out, I have not heard from her. So she was over the moon.
so you don't follow like in the long term. You kind of just do the
For
one.
this case, yeah, and that was what I was trying to figure out, like in terms of fitting it into, in my dream of kind of with radiation medicine and having us be more integrated in longitudinal, especially as the 5 fraction or single fraction things take over, and we lose that sort of specialness of the, we used to have these very long longitudinal relationships. That would be one way to build back in. That kind of ties into us becoming more entwined with being the primary sort of workup and diagnostics of osteoarthritis. But in this moment, what I'm doing, and now assuming whenever I discharge somebody like out to the wind like that, I always make sure that they have follow up otherwise. So assuming they have other physicians they are following with,
Yeah, like primary
yeah.
care. Yeah, or like
Then right
yeah.
now I'm just kind of sending them out into the wind. Long term, I would absolutely love to kind of have much more of a comprehensive sort of presence. But yeah, in the moment, that's what I'm doing.
I was thinking I might see him back at a year.
I love it.
I don't know. This will probably.
I,
What was
I
that?
love it. I think you can, especially, well, so for you, and this goes into practice building, I think your setup where you guys are trying to like establish service lines and relationships and things, I think actually an amazing thing for you in your situation would be a multidisciplinary clinic around this. Like,
Yeah.
and so seeing them at a year makes total sense as you kind of like build up this novel service line.
Yeah, I'm gonna see how it plays out. There's definitely there. So there. I guess we probably don't have like time to get into the weeds on this, but there is motivation to kind of do a registry. So that's one reason to have some kind of infrastructure where they're sort of
That's a
followed,
good point.
and then it gets into the whole how do for me, I just can't resist like thinking about measuring this and like and like wanting to know like objectively how people are doing
I
as a
guess,
group over
yeah,
time.
and so several
Um,
you and I have talked about this at length, and then I know I have several friends who have talked about this. So ultimately, when I get to my new job here in a couple months, you and I are going to try to really do that. So there is for people who would be interested in doing that with us, at least in the very beginning, trying to do just nuts and bolts, prospective registry sort of things. In that case, 150%, we'd have like a protocol for like this is what you follow up and score and stuff, which I know you and I will engage
yeah.
in. So we'll probably open that up to whoever wants to do that with us.
And it's challenging. I have to read a little bit more about like how this stuff is measured in the osteoarthritis literature, but like it's this whole, this is very challenging to measure. It's challenging to show benefit in real life in these patients because as a group, because there's a lot of patients that'll have like multiple sites of disease
So
and other reasons for pain
interestingly,
and things like
Austin and I
that.
have talked a lot about this. So and so is mood at night. But basically, you know that I'm totally blanking on it. It's the VAS, the visual assessment scale. So a lot of hospitals, and I know mine is already doing it. When patients come in on the intake form, they use that smiley face scale. So that's the VAS. That is actually one of like a metric that's used a lot in pain. So then, yeah, because now we're wandering in the research thing about pain management, and so that literature, you're right, it's very difficult, and that's why people shy away from this. Is there's not hard endpoints. There's no PFS of osteoarthritis, and so that.
Well, and even on top of that, I mean, I think everyone kind of just knows anecdotally from like med school and just from seeing patients that people, or even in people, people in their life, people have good and bad days. Pain is impacted by a lot more things than just how the joint is
Oh,
doing.
absolutely.
So I think, yeah, so I think it's just challenging to kind of, so it's funny when you read these trials, because I think to me, the few trials that I've read recently that are looking at other interventions for osteoarthritis that aren't hip replacement or joint replacement, it's noisy data. So I think that
Well,
in general, it seems like a really good treatment. And so having local data just showing that people are doing better, I think it really cements this as a valid treatment in the kind of local hospitals options for people who have osteoarthritis.
yeah, and I think it's really great that Simil tweeted what he did today. So Simil had tweeted out asking about kind of surgery. So for me, because like there is trying to actually quantitate the pain response, which is very, very difficult. What I actually think is not more valuable, but valuable and easier to measure is either delay to surgery or reduction in analgesic use, certainly narcotic use, but just any analgesic use. And, because ultimately what I see this as, it seems far-fetched to me where if you have somebody presenting for arthritis that you deliver low-dose radiotherapy to, it's probably not going to give them a benefit for their whole life. It might, I don't know, but I think that person at some point is going to require additional intervention. So actually the knee woman who had a complete response, she came and how we were talking about it was that she had conservative therapy, so your classic sort of NSAIDs and Voltaren gel and physical therapy and all that, that had failed in that it still lasted for like 6 to 12 months, and at that point the orthopedic surgeon that she was seeing had floated the idea of doing a knee replacement, and this is only after like a year. A knee replacement is obviously a huge surgery. It's a big deal, and that was what she was trying to avoid. And so she did the low-dose radiotherapy, and now, she would have, if she hadn't done that, she would have probably already had the knee surgery at this point. So I think to me, that would be an incredibly valuable and much easier to measure is, delay to surgery, and or sort of reduction in analgesic use, and that was in Simil's Twitter thread today. So because in terms of this is like the ultimate choosing wisely. So in vogue to talk about financial toxicity. I will actually, I didn't have time to prepare it for tonight, but if you look at the cost of like a 6 fraction, especially doing complex isodose, but 6 fraction 3D or 6 fraction complex isodose course of radiotherapy compared to a joint replacement surgery and recovery, the risks and benefits and costs, like it's not even, radiation blows it out of the water. Like I think the last time I looked, I'll have to, I won't say it's in like 30 to 50,000 is like the last I remember. And I'll actually math that out. And then you're hospitalized, there's infections, there's all this other risk. And then also compared to kind of a lifetime of medication. So a lifetime of diclofenac or, whatever else, or physical therapy. So if you can deliver 1 to 2 courses of 6 fractions of radiotherapy, even if it is the lofty 3-dimensional radiotherapy, the sort of benefit to the patient and society in terms of cost and side effects is just incomparable. So that would be kind of the ideal, in my mind, one of the ideal sort of measurements.
Yeah, and I would actually add that I bet you, the way I think about it is it's actually probably more cost effective than a lot of the other therapies that are not joint replacement that people kind of use to bridge or kick the can down the road. And so that's the way, that's actually the way that I've kind of framed it in my head, at least, is that, I actually saw somebody today that we talked about it, and they hadn't even tried PT yet, and they'd already been referred. And I was like, that's, to me, that's the first step for every patient, because you can fix some of it that way. And that, that's how exercise is great all around. So I think that that's good. But it's like for people who have failed PT or like Voltaren gel, like you said, and they're looking at more aggressive interventions like injections or, more expensive medicines, there's a lot of space there between that person and then, like, getting a hip replacement. Right. So The other thing that is a cool concept is, Wash, you had a really cool center that was PM&R based, and the goal of it was to basically prehab like kind of borderline operative risk patients into health enough to be like less risk for the surgery, right? That was like the goal of
Yeah.
the center. And so like you could imagine like radiation plays a really nice multi-D role in that patient because you basically can alleviate their pain for the 6 months or a year it might take them to lose weight and get more in shape for a surgery. So those are the kinds of things that I think about when I was like, where to frame this. But again, like one of the things I really want to study in the next couple of weeks is just reading a lot about how people are managed between physical therapy and surgery, and just kind of understanding where this might fit. Also, where you might test it against in a trial.
I hadn't even thought about that. Well, so I guess because we'll make this the real teaser episode, because so I launched a few startups this summer that Matt and many other people are involved in, and kind of around that space where where things like this of using low dose radiation, but also other things that we do as part of our quote unquote regular job as cancer doctors, really lends itself to when we have an aging population and an increasingly expensive healthcare system. There's a lot of places that we can kind of become involved to not only kind of give ourselves a bigger role in just American medicine, but also in terms of benefit to society. Because I think we've been sort of self-stigmatizing, but that there's this misconception that radiation therapy equals expensive, which is in this case just not true. And I think if I'm very excited now to hear about how Centura is doing it, where if you can kind of have like a multidisciplinary sort of clinic sort of deal around sort of I've been saying this all the time, of the unsexy stuff of just the day-to-day grinded out like prehab of just the boring maintenance things that aren't going to get you grants or plenary sessions, but they are going to help a lot of people lead better lives and be less of a cost to society. So I think that's what really gets me excited about this. Is even so, my father-in-law, I got really interested in this starting probably back in 2017, 2018. Part of what got me interested in this was that my father-in-law had bilateral knee replacements at the same time, and then like basically refused to take pain medicine. And that was one of the most excruciating things I have ever seen in my life. And I am now terrified of that. And I can't believe he did that. I think about that all the time. And, but so if I could have bought him 6 months of just not having bilateral simultaneous knee replacements, I would have done it 100 million times over. And so that's what I picture, is just buying someone an extra 6 to 12 months of that, or in a prehab sort of sense, if that's what it takes for them to get to a lower weight and to improve, it is worth it every single time.
Yeah. No, those are all really great points. And I think that you're exactly right. And for me, the overarching thing that makes this rewarding, or, an additional thing that makes this rewarding is it's kind of just, that recently I was doing a networking thing with some primary care doctors, and one of them said that radiation oncology is the specialist. Yep. And I was like, and it was funny, and he's totally right. But it sort of hurt a little bit because I don't think that's how it should be. I think that we should be a field that can manage, can be the entry point for the patient into the multi-D management of how everything is now. And so this is just something, again, where I think the way that this is framed, you're kind of, again, another tool in the primary care provider's belt that, instead of referring to rheumatology for a medicine or to ortho for a joint replacement, they could refer to radiation oncology.
Exactly. So I love that idea. Yeah. And for me, now I know not everyone's going to want to do this. I envision a day where, I am like the point of care for this, where with the already incredibly burdened, PCP system, where if they can just have somebody come in with joint pain and say, go to Dr. Becta, he's the joint guy, and then be that kind of touchstone. I also am the kind of guy that literally just sent an email asking someone to teach me how to do skin biopsies so I can do my own in-office skin biopsies, because I'm tired of patients like showing me something. I'm like, yeah, that does look like cancer, but I can't do anything about it. See you later. Come back when this is done. So I'll be out here doing skin biopsies and the primary workup for osteoarthritis. But people don't have to go that far. But
I think it's all based on local need, right? I mean, it's like if you have, there's definitely radiation oncologists out there that like maybe they, their patient can't get into a dermatologist for 5 months.
Like everywhere. That's right? Everywhere, as far as I know.
Yeah. And right. So like, that's, I think that there's examples of that everywhere. And I don't envision myself doing it, because I think that the primary care groups that I've been working with are very strong, and they seem to, want to be the one to probably diagnose it and kind of decide where they go. But as we said, I think doing that at any level, whether you're further up the chain and diagnosing it yourself or just being the first referral as a specialist, I think both of that is big upside for
Yeah,
our
that's all with
field.
it. And that's why,
So
rebranding radiation medicine. I'm going to try to, I'm slowly,
yeah,
I still say rad onc and it hurts me on the inside, but, rad med, radiation medicine, rad med.
RadMed, I like
That's
that.
what,
Yeah, is it? I think isn't UC San Diego RadMed or someone's
so,
radiation
well, it's funny
medicine,
because
right?
at Yale we were
Yeah.
therapeutic radiology, but it was, Todd reminded me that the infamous, or not infamous, the esteemed Dr. Charles Thomas, he's where Todd heard that, and I know somebody else was using it. So,
Oh,
um,
maybe it was OHSU
I,
then. Somewhere, definitely someone uses it like officially. It's like their title is Radiation Department of Radiation
Yeah,
Medicine.
I think if you
It might
Google it,
be.
there's actually a couple. It is so if you Google, because I
Yeah.
actually now I own I think radmed.com, but there's other things, but yeah, I like radiation medicine a lot because that's really what we can be, and therapeutic radiology is a little bit lofty, but radiation medicine, I think that's what we should strive to see ourselves for. And then I always get made. So I did a really sort of intense preliminary internal medicine year, and so I always get lovingly, I'm going to say lovingly, called medicine man Becta. I have a certain real strong affinity for internal medicine, so that's just kind of my bent. But
So I just Googled it. OHSU has the top hit, of
yes,
course. Congratulations to them. And then UC San Diego
wow.
has the next one. And then for me, probably the third one is actually UC Health, Colorado. And they're radiation oncology. So we'll have to
We'll have to
work
look. Well,
on
I
that
definitely,
last one.
I'm pretty,
Yeah.
and now I can't, I'm blanking on my own thing. I definitely own the domain name. I think it is radmed.com
Oh, yeah. So I just searched for like department in Google. So that's probably why the
yeah.
departments came up. But and there's another one too. There's
Oh, and
Northwell
then
has
somebody
that
in
all.
some Europeans
Yeah.
use it. I think a British
Yeah.
department pops up, but yeah, no, I think that's kind of, so I guess really to summarize, it's really, you don't have to be cute about it. It's just do everything like you would normally, essentially. I prefer 3 gray in 6 fractions done every other day with a plan to repeat. Don't do daily IGRT. The most safest conservative thing to do would be to build complex isodose, but as long as it's not Evacor, 3D will usually pass muster. And then, really just I know just we've kind of self-flagellated for so long into thinking that we're just such a burden on society, but really, honestly, compared to the alternatives, doing this is significantly cheaper compared to joint replacement for sure. And just like in terms of talking about gynecomastia or heterotopic ossification, NSAIDs and those things have side effects, and having somebody be on a daily pill has other kind of unforeseen things. So it's a very sort of cost-effective thing, and it's real. Like, I know it sounds kind of hokey, and to actually, once you see it, like, I really wish it definitely sounds wild and kind of thing. Like, you don't see side effects really, which sounds crazy to say, and then you'll definitely have people come in and say that they feel completely better, and it's wild. I still don't believe it myself, and I literally see it with my own eyes and do it, and it's still crazy. But just give it a shot.
Yeah.
It's pretty great.
The last thing I wanted to add is exactly that. So but we're gonna end right on time.
You're
We're
nailing it.
right here. So, but what I was gonna say was that's exactly, so that exact thing was how I felt with at the very beginning of Lattice.
Oh yeah.
Because I went to that symposium and it was just the symposium. It was an NCI, like, RRS, whatever, or RSS symposium, but it was essentially a series of case reports, right? Because there's not like big trials or anything. So it was a bunch of these little case reports or little, case series, but it was all these people like just passionately being like, this really works. There's something special here. And so talking to the people that are doing this and hearing, these individual cases of how people have amazing pain responses and they do well overall, it really, to me, just, it feels very similar. So I think that's the inspiration.
I love that. I love it. And yeah, for me, I'm comforted by the fact that I wish there was an accurate count. It's got to be kind of worldwide. Over 100,000 people have to be treated with this in every place but America. So it's not exactly we're reinventing the wheel. We're just kind of finally being late to the party.
Oh yeah, this must be hilarious to listen to.
I know. I feel like this feels so silly. Where Americans were like all nervous about this. Like Degro literally has guidelines on this, and we're like, guys, you should try it. Really, it's okay. Yeah, I know. Sorry, rest of the world.
No, but really, honestly, thank you to them too, because these resources are fantastic, and it makes it like it's so easy to just like, I mean, again, I just sent the paper and everyone's like, yeah, this is legit, let's do it. Yeah. So I think it's
we'll get there
awesome.
eventually, guys. I promise. I get there. But all right, so we're gonna end on time because we made promises to our spouses.
Thank you so much for the help. I really appreciate it. I'll have to let you know.
Oh, absolutely. And I'm sure anyone, we'll do a bazillion of these. So we'll continue our practical talk about Lotus RT for osteoarthritis. But all right. So thank you guys, and be well. Thanks for listening to this episode of Out of the Basement. You can claim CME for this and any other episode by following the link in the show notes. You can find me on Twitter with @DrBekta or visit www.bektamd.com. If you like this content, please let us know by rating and following us on Spotify or Apple Podcasts. If there's any topic you want to hear covered, or if you want to come on and talk about something yourself, reach out and let us know, and we will make it happen. Otherwise, talk to you next time.